So I'm going to start and give you a little bit of background on the study, and then Dana and Joan will follow. So we also want to acknowledge Ron House. Ron House actually was the co-PI with Joan Eakin on this study, and it was funded by Bridging the Gap award from the WSIB. The study actually came out of the Center for Research Expertise in Occupational Disease, CREOD, and actually from its advisory committee. Early in CREOD's life, the advisory committee kind of sat down and talked about issues that were broader than specific diseases that we were focused on, and one of the questions was underreporting. So this is really the outcome of that discussion. So we're going to briefly review the background and purpose of the study. Dana's going to talk about the design and methods, and then Joan will present the results and implications. So the study really focused on occupational disease coming out of CREOD. We kind of talk about occupational health and safety and occupational disease throughout the presentation, but the original focus was occupational disease. So people generally accept that occupational disease is under-recognized and underreported, ranges from 40 to 90%, depending upon the disease. And there's also some conversation, which we'll hear about more, around over-recognition and over-reporting. So one of the concerns for under-recognition and under-reporting is, first of all, workers do not see compensation benefits. And if they have a serious disease, it's not only their health care and employment benefits, but it's also potentially survivor benefits, quality of life benefits. So in fact, it may be a very large suite of benefits which they do not receive if, say, their occupational cancer is not recognized as occupationally related and reported. Again, if things are not reported and adjudicated, the healthcare costs will be borne by the public system as opposed to the compensation system. And certainly of concern, I think, it also means that if these diseases aren't recognized and reported, they don't appear in the WSIB statistics, so it appears that disease is not that important. And equally, when one's talking about prevention strategies and you're using as a basis for what are we going to look at and prioritize WSIB statistics, it appears this is a very small kind of piece of the pie. So the reality is, as I say, although we all talk about underreporting, when you actually go to the literature, there's not really a whole lot there. Where it's there, it talks about physician challenges, workplace challenges, and structural determinants. And in studies that have been done, they've tended to look at it one component. So as I said, there's very little work that really holistically looks at the problem. The physician and diagnosis challenges, failure to make the link between exposure and disease would be an under-recognition issue. You never recognize that it's potentially work-related to start with. Underreporting, a variety of administrative barriers and requirements from the physician's perspective. There are no negative consequences for the physician for not reporting. Neither is there really lack of any positive reinforcement for reporting. At the workplace level, fear of retaliation. Often it's kind of, well, these symptoms are just typical of I'm working here or related to aging. If workers have had other experiences with the compensation system, they may say it's just not kind of worth me doing this. And also concerns around losing their job or even having to change their work within the same organization. And then also structural determinants, safety incentive programs, and even forms may be an issue in the actual overall system. What's interesting is just in the last few months there have been two studies of contact dermatitis, both from Denmark, where they looked at a group of workers, hairdressers and healthcare workers, who had hand eczema, who again were viewed as having occupationally related disease. In the case of hairdressers, only 21% have reported their disease to the National Board of Industrial Injuries, and for healthcare workers, in fact, it was only 12%. So there actually are some very recent kind of hard numbers around the fairly significant underreporting around dermatitis. For the hairdressers, they actually pursued that and kind of said, why didn't you report? And some of the typical answers were, I thought I'd get better, my doctor didn't tell me it was possible to report, I probably wouldn't gain anything if I reported it, the process seemed difficult, I didn't know it was work-related, I was worried about problems with my employer and afraid of losing my job. So as I say, that's kind of a background. Basically, we kind of know underreporting exists, but there's not really a really good solid body of evidence. So the study was really designed as a first step to inform a more comprehensive research design going forward. So we wanted to clarify the key concepts that underpin research in the area of under-recognition and underreporting, to really try to develop a taxonomy of stakeholders' language, to identify units of analysis needed to address this area of research, to identify determinants of recognition and reporting, and to understand better the socio-politics of doing research in this area.
To address the 5 goals that Lynn described, we used an interpretive qualitative design involving focus groups with key stakeholders. And we had set out to do focus groups with 5 key stakeholder groups: healthcare professionals, union and worker representatives, employers, injured and ill workers, and the WSIB. But as recruiting got underway, we quickly realized that the WSIB perspective really needed to be collected from several areas within the WSIB. So that resulted in a decision to do 3 distinct groups from the WSIB, which included operational directors, frontline operations team members, and frontline occupational disease team members. And we chose the focus group design because we were interested in observing the interactional aspects of the group. So we were really interested in seeing how members of the group would co-construct a perspective by challenging or supporting or learning from one another's contribution, by deferring to others in the group according to hierarchies within the group, and also by presenting an image of themselves or their group to each other or to the interviewer. And we grouped stakeholders from key groups all together in order to get a fuller, more rounded out perspective. The recruitment process revealed some challenges to doing this kind of research, so I just want to sort of talk about that for a couple of minutes around some of the challenges we have with recruitment. And they vary across groups. So the more well-networked, connected, and engaged groups that we found we could recruit relatively easily was the WSIB, the 3 groups from the board, as well as the union worker representatives. So there was already an interest there amongst those groups in underreporting. Other groups, however, were more challenging. So a key barrier to involving healthcare professionals in research is their busy schedule. So we endeavored to address that by holding the focus group through dinner immediately following their clinic hours. And the goal was to bring together a mixed group of experience coming from industry, community, and hospitals. And what we wound up with in the end was a cohort of 5. We had, let me see here, 3 physicians, 1 community-based and 2 industry-based, 1 nurse practitioner, and 1 physiotherapist. To recruit injured and ill workers, we contacted clinics in the area that we knew served this population. And we were only able to attract 3 individuals to the focus group. And it seemed, once the group got underway, that the workers were somewhat uneasy kind of opening up and talking to us. So we think that perhaps one-on-one interviews would be the way to go in the future, and that may have encouraged more participation in the group, in the study. Recruiting participants for the employer group was extremely challenging, the most challenging group for the study for sure. So we started out by contacting all the employer representatives that are already sitting on WSIB-funded research centers, because we anticipate an existing interest in research participation. So we contacted 10 companies and identified 3 participants, but only 2 attended in the end. And it's important for us to note that really neither of those participants were employers per se. 1 participant worked as a consultant for employers, so doing risk assessments and investigating complaints. And the other participant was a healthcare professional working in a human resources department, so basically offering workplace health services. So we must be cautious in interpreting this data in terms of making any attributions to the particular group of employers. And certainly in doing research going forward to engage employers would require, I think, new strategies. The focus group discussion topics were designed really to elicit data relevant to those 5 goals that Lynn finished off with. And because the project was exploratory, we wanted to keep the questions really broad, and we wanted the participants to provide and use their own definitions of reporting and recognition and those various terms we were studying. And we resisted in imposing our own definitions on the group. And so what happened was that a lot of the participants were kind of uncomfortable or struggled with the questions, and they were worried that they weren't talking about the right things. And in many cases, it seemed that the terms recognition and reporting weren't even all that meaningful to the participants. And while they would talk about those phenomena, they wouldn't necessarily use that language. And this is just a sample of some of the questions we posed in the discussion group. These were just designed to sort of facilitate discussion. We sort of tried to let it happen as dynamically and as organically as possible, but had some questions ready. When we talk about reporting of occupational injury and illness, what comes to your mind? So a very sort of broad kind of question. How does reporting matter to you? Does it have implications for you doing your work? Who and what influences reporting of occupational injury and illness? Focus group sessions were audio taped and transcribed, as well as the recorder's notes. They were also transcribed and included in the data set. And then all transcripts and notes were imported into a software program, Atlas TI, which helps organize, manage, and analyze qualitative data. Data were analyzed using a straightforward content analysis approach, according, again, to those 5 project goals. And also using a more interpretive qualitative analysis. So that was aligned with the theoretical perspective on focus groups. So as I mentioned earlier, because the mode of data gathering is itself an important influence on what is said in the group, we wanted to consider the relevance of that in interpreting our data. So for example, in the WSIB group with members of the frontline operations team, the managers were present. And so we wanted to consider how their role impacted what was being said by the other members in the group, or not being said. The more interpretive analysis involved careful interrogation of the data with particular attention paid to language, what was said and how it was said. And attention to language was really central to our analysis because it signals meaning and it reflects how the participants understand the issues we were talking about. So for example, as participants talked about the notion of incidence in talking about reporting and recognition of occupational injury, it really reflects a preconception in the system toward injury. And it's suggestive of how the term is conceived and how it's framed in terms relevant to discrete events and injury rather than disease. And it reflects an underlying understanding of cause that is clear and observed and of immediate effects that can be seen and reported. So that's just an example of how we paid attention to language. A key feature of the analysis was regular team analysis meetings. So at various stages of the project, I would produce a report of the findings that were emerging, and we would review them together as a research team. And important findings would be discussed, and new interpretations of the data would emerge. We convened numerous times to talk about emerging ideas and concepts and how the findings would be organized. And we also met with the steering committee and reported preliminary results to them. And we took back the dialogue from them, their responses to that report, and included that back into the data set and our analysis. As the focus group design came together, the team decided to build in a complementary exploratory arts-based component. So we invited 2 artists to participate in the project and asked them to sit in on, observe either the research meetings or the focus group sessions, and then render in art form their interpretations of what they heard. So the first artist was Susan Scott, and she's a graphic artist, and she creates art in her work as a consultant in human and organizational behavior. And she created a...
So we'll pass these around.
She created a cartoon image to capture visually what she heard in the group dialogue. And as you can see, it's sort of a take on a snakes and ladders game. And the second artist, so her work is on the opposite side of what's being passed around there, was Emily Holton. She's a writer, an artist, and a KT specialist at the Center for Research on Inner City Health. And she attended the steering committees and the focus group sessions. And she synthesized what she heard in all of those sessions and meetings into an illustrated story, which was later created into an audiovisual presentation. And the illustrated storybook and the game there became additional sources of data for us, and they were considered in our team analysis meetings as additional data. And they also reflected or highlighted emerging findings that were coming out in our analysis of the transcripts. And the use of this arts-based component in this study really highlighted for us the important role that these sorts of products can have in salvaging or reconstituting non-textual, non-audible, emotional type data that tends to get lost when data is transcribed, analyzed, and so on. So I'm going to hand it over to Joan now.
Okay, so to summarize where we are till now, the purpose of this small project really was to try to get a grip on and deepen our knowledge of the core concepts and what forces were at play in understanding issues of reporting. So that was what we were trying to do. And we learned a lot from the inquiry, but we obviously can't present everything here by any means. So we're just going to present a few of our findings to generate some discussion and to give you a flavor of what we've been doing. Now, the first thing we can look at is the issue of how the concept of reporting is understood. Our project signals some significant differences in how it is conceptualized and understood and used. For example, reporting can be seen as about incident reporting. Dana has already mentioned that. Here, reporting refers to very specific events in the workplace for which cause and time and date can be established, and which are to be reported to a supervisor, let's say, or put into recorded in a logbook. As this WSIB staff member comments, the first thing, I guess, is on the shop floor, is the treatment record book. Usually when a worker has an injury or any kind of medical concern, they should go to the treatment record book. Let their supervisor know. That should catch all incidences. Now, catching all incidences invokes a sense of counting and keeping record for purposes of generating statistics. The quote also illustrates the association of reporting with the act of telling an authority. The speaker talks quite normatively, talks about what should happen. And we found, in fact, the weaving together of normative and descriptive explanations runs through the data and hints at the moral overtones really associated with notions of reporting. We'll pick up on some of this. Now, the term reporting was often used synonymously with filing a compensation or completing the various WSIB forms associated with a claim. So reporting is seen here as an act that involves professionals as well as workers reporting. It hints at how reporting becomes associated with particular institutional forms and practices, perhaps eclipsing the broader conception of the term of reporting. We also have reporting as recognition. Recognition of work-relatedness and also recognition of reportability. For example, workers may not see the condition as being due to work, or may consider an incident or a condition as just part of the job, or may not understand that that a certain condition is eligible for compensation. So the issue of recognition or the lack of it typically arises mostly in relation to occupational disease or gradual onset kinds of injuries. But implicit in most of these conceptualizations of reporting is the default assumption that the conversation is about underreporting, why things don't get recognized, recorded, or reported. But we also flagged in our data the notion of overreporting. Overreporting also is conceived in a variety of different ways. Overreporting can be seen as a kind of misuse. And here we have, you get people who underreport and don't report anything for 5 years. But then you get people who, you know, I've got these symptoms and I'm exposed to something at work, mold or perfumes or anything like that. Therefore, everything that I've experienced is related to this exposure. Overreporting is also seen as associated with workplace benefits that allow workers to accrue sick leave to use as vacation time. This is seen as associated with overreporting. Or over-reporting is seen as a means to maintain seniority in situations where seniority is affected by sick leave, but not by compensation claims or being on modified work, return to work. Over-reporting, curiously, was also used at times to describe claims that were not accepted by the WSIB, in some sense signaling that if only real claims are accepted, that then those that aren't accepted are somehow constitute over-reporting. The issue of legitimacy also appeared to underline concern that over-reporting should result if problems are seen to involve non-work-related causes. Here we have a WSIB staff member commenting that the work did not cause the problem exclusively or in its entirety. So in a way, employers would then be paying for many of the lifestyle factors. And if work causes 1 in 10, and at the individual level, you'll never know which of the 10 it is, so you have to compensate all 10. So really, there's a potential for underreporting then that becomes explosive potential for overreporting. It's a bit convoluted, this statement, but it's essentially getting at the kind of the problematics of when non-work-related issues are involved. It raises issues and the distinction between under and overreporting. Now, underreporting is also seen as precaution. The Program Exposure Incident Reporting Program at the WSIB provides a means for workers to report incidents in their workplace, such as a spill or a leak or an explosion or other thing that could have potential could be so that potential exposures and problems down the line could be documented. This precautionary reporting is also sometimes understood as over-reporting or called over-reporting. The reporting of near misses and other precautionary kinds of reports are also sometimes considered as over-reporting. Multiple reports of a single incident from one workplace can be difficult for the WSIB to handle and prompt them to perceive these reports as administrative nuisances that detract from time and resources that should be spent on more fully obvious disease claims. For example, here the comment, 30 workers were working at X company and something spilled and they think maybe they'll have a problem 30 years from now. To collect information on hundreds of thousands of what could one day be a disease, when we're missing obvious diseases, it seems a whole lot of effort expended to an initiative that isn't likely to glean much because it's all uncorroborated. Now, it always sounds a bit funny when you see words and so on flat on the page, but the idea is that this can be seen as over-reporting and unnecessary over-reporting. Now, over-reporting, a final conception of over-reporting refers to the situation in which a company may comply fully with reporting requirements, but because such fulsome reporting isn't the norm in the industry, it's understood as over-reporting. So we've given you a bit of a glimpse of some of the variation in how concepts of under and over-reporting are understood and used. So how do we account for such divergent meanings and uses? On the basis of our analysis, we would propose that reporting is essentially a judgment, and that judgments are made differently by different stakeholders and are governed by the stakeholders' location, their role and positioning in the system. Participants' understanding of the matter of reporting is shaped and framed in important ways by their accountability, to whom they are answerable, their professional commitments, and their positioning, really, in the occupational health and compensation systems. A specific example of the significance of location lies in the differing perspectives of the three groups from the WSIB. For example, frontline staff spoke about reporting in terms of workers and employers reporting. And adjudicators working with occupational disease saw reporting much more in terms of healthcare providers' practices. And the WSIB staff at the director level, who don't deal directly with claims, approached reporting more in terms of trying to balance the incentives to report with capacity to pay, and to balance those kinds of incentives. These differences gesture to how reporting is understood through the lens of particular locations and institutional commitments. So until now, I've been talking about our findings related to the conceptualization of reporting. The second set of findings, which is sort of shifting position a little bit here, is to relate our efforts to understand understandings, is to get at understanding what influences reporting practices, obviously, as our respondents saw. So parallel to the diverse conceptions of reporting, there are diverse ways of explaining the influences on reporting. From the focus group discussions, three main categories of determinants could be distinguished: individual level ones, workplace level ones, and system level influences. So starting with the individual influences, with respect to workers, the common refrain was that underreporting was due to lack of awareness of potential hazards and conditions in the workplace, underestimation of the seriousness or the extent to which problems impeded their ability to work or compromised their income. With respect to healthcare, well, that's workers. With respect to the healthcare providers, this is healthcare providers, was mentioned insufficient knowledge and training regarding occupational health problems and actually the work and working, the indices and the work of their patients or clients. And also an familiarity with certain things reflected here. Healthcare people say, oh, there's a very large automotive manufacturer and these guys always have musculoskeletal injuries. They just never at all thought about asthma. And they're familiar with certain things and don't see others. There's also role confusion. For example, doctors may not file a WSIB form because they wrongly assume that they need to diagnose the condition as occupational in order to file. And they don't consider the condition to be work-related. This is sometimes rather sniffily called pre-adjudication by people at the WSIB, where the physician makes the judgment as to work-relatedness before the claim gets into the system where it's deemed to belong. Then there's the perceived legitimacy of the complaint as being an influence on reporting. We see here yellow flags go up when a worker goes way beyond the duration of the guidelines in terms of healing. Or performance issues, you open a file and you realize that immediately the guy was scheduled to be disciplined and suddenly he went off work. So here you see a reluctance to file a Form 8 is sometimes seen to reflect the healthcare provider's assessment of the worker's honesty, rate of recovery, and level of job satisfaction. In contrast to seeing the patient's claim as illegitimate, we also learned that doctors can be seen to over-report because they are thought to believe rather than disbelieve too readily their patients. And they file forms without corroborating reported symptoms with objective tests. So there's the opposite side here where when you believe too much your patients. Now, the determinants of reporting are also attributed to the workplace as opposed to individual practices. For example, workers can be deterred from reporting work-related problems by the social disapproval of coworkers. For example, in the case of an injured worker doing modified work and getting the same pay in work that involves tips can generate a lot of ill will at work. Or in some trades where jobs are male-oriented and require heavy manual work, so-called machismo, was seen to deter reporting of many conditions related to back pain. We all have back pain, suck it up kind of thing was mentioned. Employer pressure was also noted. There's employer pressure to keep down the firm's rate of claims and to handle problems in-house. And this was also seen as being a determinant of underreporting. Employer pressure not to report work-related problems was also noted in connection with safety programs. As one worker put it, they, the employer, were very proactive when it came to WSIB. They had gone 2,000 plus days without a lost time injury. It was a benchmark for the company. There was a display board when you came to the parking lot. However, they, the workers, didn't want to report it because they didn't want to be the one that brought that number back down to zero. Then there's also the issue of reprisal, which has come up before. But the perceived risk of being fired or getting crummy jobs or shifts was also seen to suppress claims filing and reporting. And the presence of a union was understood to increase awareness and support of workers in filing compensation claims. Although cluster claims can be seen as a legitimate and useful consequence of enhancing awareness to union activity, it was interesting that some also perceived it more negatively as over-reporting. In addition to individual then and workplace determinants, we also heard reference to reporting as being influenced by institutional and system level sorts of policies. In relation to the WSIB, underreporting can be influenced by the perceived success rate of compensation claims. When people aren't winning claims, other people aren't going to file claims. Like the rate of success affects the extent to which people put in claims and report. And then there's forms. Reporting forms such as 6, 7, and 8 were thought to play a role in deterring reporting of occupational conditions, mostly for reasons of inefficiency and inconvenience. They're too onerous. They make irrelevant requests for information. The process is complex and there's no online access, those kinds of things. I thought it was interesting that the more subtle implications of the power of forms and their structure didn't appear to be visible to the people we spoke to anyway. Now, reporting can also be affected by the perception that WSIB might be operating with, quote, old science that has been discredited, and also that it cannot recognize new problems for which there's not yet the science, because they're science-driven. It's hard for them to acknowledge new diseases and new problems, which of course is a deterrent to filing, to reporting. Experience rating programs reward and penalize employers according to their claim rates, is viewed as an incentive to achieve better health and safety records. However, the program can be also understood as leading employers to discourage workers from making a claim, and that point is often very vociferously made. Participants also noted that the WSIB is not out there, quote, shaking the tree for more reporting, as they're having enough difficulties dealing with what they've got, so they're not out there looking for more. Additionally, the WSIB might not be drawn into reducing underreporting because they are accountable to employers who might not appreciate shopping around, as we were told, for claims, as one WSIB person told us. Moreover, although the WSIB is engaged in education and outreach, in principle can increase awareness and access to reporting and claiming. But any increase in reporting, of course, can mean increased costs. So it's kind of a dilemma for an organization that is attempting to reduce its financial liability to get involved in enhancing reporting. Now, these various perspectives point to the tension between reporting, organizational capacity, and implications of identifying the actual burden of unreported injury and illness. We also see structural level influences here related to employers. For example, employers might not be registered with the WSIB, the so-called underground economy. They don't report workplace injury and illness to the WSIB, and it's reasoned they're likely to manage incidences in-house or to prevent their employees from reporting in any case, or passing it on, just expecting them to use OHIP rather than occupational health. Employers have a large financial stake in their own claim rates because of its potential to raise their premiums. And it also might disadvantage them in terms of bidding for contracts. There are also structural influences related to healthcare providers. The shortage of family doctors, for example, and the subsequent lack of continuous health care for injured workers leads them to use walk-in clinics. And of course that reduces the chance that they are going to have occupational problems recognized and handled and reported, because occupational conditions require ongoing visits, multiple visits, documentation of work history, medical examinations, and so on, which just doesn't happen in those kinds of settings. There are also complex and inadequate communication between the WSIB and healthcare providers, and it can deter healthcare providers from getting engaged in claims. It's just too much hassle, too complex. And there's financial incentives for healthcare providers. It's known that it can encourage more thorough evaluation of work-related problems, and raising fees for completion of Form 8 above OHIP levels is also believed to have increased reporting by emergency room physicians, for example. And then there are structural influences related to workers. The economic and political constraints on reporting are many, including being in the country illegally, or living in communities with very little employment opportunities, or living in single industry towns, where to report risks not loss of job and maybe loss of employment altogether. It's a pretty big cost. As a small firm size, there, I went too fast. A small firm size is also thought to reduce reporting because workers there are more vulnerable and have less access to information about reporting. And so finally here we've got structural influences related to worker representation. Now, the representation of workers, despite its commitment to and role in reducing underreporting, is itself limited by lack of resources to meet demand. And so there's a kind of a ripple effect of not being able to represent injured workers means that the success rate of claims may go down, which in turn reduces the incentive for workers to put in claims to report. And then there are structural influences related to the system as a whole. And here we might include things like the discourse of abuse. In this study, we picked up elements of what has formerly been identified by me and others as the discourse of abuse, the prevailing expectation that that workers might file claims that are not work-related or that are exaggerated or falsely presented in some way. So fear of being suspected of malingering or of taking advantage of, quote, easy money, which flows from this discourse, can be a profound deterrent to reporting. Also, in our system of disability insurance, work-related disability, as you know, is treated separately. And the consequent need to determine work-relatedness is the source of much difficulty and conflict, and is seen as a significant determinant of underreporting by accentuating the challenges of claiming and the associated stigma for workers, and the stakes and the risks for employers in the process. Now, cutting across these different concepts of reporting and these different senses of how they influence things are different differences between occupational disease and illness and injury. Occupational illness has a number of attributes that impede recognition of occupational of reporting. The absence of an acute discrete event or a start line, development of symptoms over a long period of time, difficulties in medical diagnosis and claims adjudication, and also challenges related to the multifactorial etiology. As one worker representative said, the closer the disease gets to being caused by other factors, the less likely it's reported as occupational. That's a given. Now, these attributes can contribute to underreporting in several kinds of ways. The compensation system, including its forms and its practices, its procedures, is seen as being oriented to injury, which is an impediment to the reporting of occupational disease. See here it says designed toward musculoskeletal injury, so someone with dermatitis or cancer or any disease might be stumped as to how to fill it out. The WSIB's emphasis on objective medical evidence for demonstrating a condition is as work-related and for approving claims also reinforces a certain bias towards injury. The board's schedules determine what kind of conditions get reported, but there are diseases that are not listed in the schedules but are still eligible for compensation. And those may not get reported because workers or healthcare providers are not aware that they indeed are recognized and might be compensated. There are a whole set of conditions not listed that we would compensate on a case-by-case basis. People might think because there's no policy on it, I would not make a claim. The effort to rule out other factors besides work can entail a lot of scrutiny of workers' private lives, which workers can experience as invasive, punishing, unwanted in any case, and it can seriously deter them from reporting. Employers may also be discouraged from reporting occupational disease when non-work factors are involved. It just makes it too messy, and they're too indignant, and so on. Healthcare professionals, you probably can't even see down there, but healthcare professionals and adjudicators might be deterred from getting involved in cases of occupational disease because of the scientific difficulties. It's not easy. It's a much tougher thing to kind of deal with, and also because they don't have sufficient time to investigate the cases properly. And we're actually seeing this a bit in another study that I and Dana are doing on studying doctors. So the issues of occupational disease are rarely considered or accounted for in the reporting literature. But they're very important as they have significant consequences for recognition and reporting of the different work-related conditions. So to sum up here, the most important things that we found are that reporting is conceptualized in multiple and diverse ways, that overreporting is distinguished from underreporting, that perspectives on reporting differ by the location and the accountabilities of the stakeholders. The implications of under and over-reporting are different to different players in the system. The influences of underreporting include individual level ones, which are more the conventional way of thinking about it, but they importantly include systemic and structural impediments as well. Injury and disease are substantially different phenomena in terms of reporting, or phenomena, that's wrong, in terms of reporting. And then finally here, not everyone necessarily has a stake or an interest in addressing the problem of underreporting, usually because of limited resources to deal with the full burden of occupational harm, were it ever to be brought into the system. In closing, we'd like to raise a few implications of some of these things. First, conceptualizations of reporting are not just of academic interest. They are embedded materially and consequentially in the processes of the occupational health and safety system, like in the forms that govern them, and in the practices that are tied to those material forms. So they get, the conceptualizations get built into the system in very material kind of ways. The different conceptualizations of reporting and uses of reporting can certainly complicate research. Like what are we talking about, and how does one investigate this stuff? There's so many different notions of what it is going on and so many different answers. So it can complicate research, and clearly, obviously, it can complicate, it can muddle organizational efforts to change. Reporting and institutional practices tend to privilege injury and to shortchange occupational disease. The substantial political and economic stakes in reporting makes it difficult to research and to change. I mean, we were originally oriented in trying to suss out some of the socio-politics of doing research on underreporting, like what might it entail if one takes on research in this area. And certainly it entails quite a lot. It does make it difficult to do research and change. And given that the problem of reporting is different for different stakeholders in the system, it's not always clear that there can be a consensus for what needs to be fixed. And furthermore, it's unclear how the occupational health and safety system could meet the demand, even if one were to actually succeed in increasing the reporting of occupational injury and illness. In other words, to get it, if it were to reflect the real burden, that it's not clear whether the system could even handle it. So that, which is kind of, these are just implications that flow from the sorts of things that we were exploring and hearing in this project. So we'd like to now, we'd really like to get your kind of responses to it, your comments, your reactions of any sort. So please.